Well, welcome everyone. Good afternoon. I hope the meeting so far is going well for you. We want to welcome you to the annual Fundamentals Symposium, where we're going to talk about various seizure medications, old and new, A through Z. So we'll get you going here as soon as the slides move. Oh, okay. So just to make a note, this educational activity is supported by an educational grant from Marinus and UCB. So I'm Dr. Tim Welty, and I am at Drake University in Des Moines, Iowa, and I'm going to get us off with an introduction to our symposium today, thinking about various medications and framing our discussion for the afternoon, and then from there, we have a number of excellent speakers who will be helping us think through a number of topics related to seizure medications. I have no disclosures related to this presentation. And these are our objectives for the entire symposium. We want people to be able to think about the older medications and how to use them and monitor them, how to utilize newer medications, think a little bit about precision medicine, and then look at appropriate treatment of status epilepticus, and then finally wrap up with, I think, a very interesting and challenging topic, looking at barriers to effective treatments when we look more globally, internationally, especially in low and middle income countries. So I wanted to start out my introduction with a case. This is actually a fellow that I saw in clinic a couple of months ago. 38-year-old man. He's been treated for over 30 years with phenytoin. He currently is seizure-free, not had any seizures for a number of times. He has a lot of the adverse effects of phenytoin. He has vitamin D deficiency, severe vitamin D deficiency, clearly has osteoporosis. He has horrible dentation due to gingival hyperplasia. There have been several attempts in the past to switch him to other medications, and they failed. Either he's had breakthrough seizures, and he's actually had a couple of episodes of status epilepticus during his the transitions. So he's been completely unwilling to think about another medication, even though he has all of these side effects because of his fear of having more seizures. And I think all of us have seen patients like this, and it starts to make us think about, why do we need all of these seizure medications? So I want to frame our whole topic in terms of what I think all of us understand, and that is that epilepsy is a heterogeneous disorder. It has multiple etiologies, as we'll see in a second, and multiple molecular mechanisms. However, when I talk to colleagues outside of neurology in particular, I don't know that people fully understand that. And they think that epilepsy is epilepsy is epilepsy. So we get a better understanding of that when we look at the ILE, the new ILE classification of epilepsies. And just simply looking at the different etiologies should lead us to the conclusion that there's got to be differences in the underlying mechanisms that cause seizures, as well as targets for different seizure medications, and that not all the medications will work the same and will hit all of the targets that there might be. So just from our classification of the epilepsies, we start to get an understanding that we may need multiple approaches to treatment, which I think all of us would agree with. Added to that is when we think about the pathophysiology of seizures, and this is just a short list of underlying documented pathophysiology of various seizures, all the way from neurodegeneration proteins to transcriptional regulators to what we all know about, especially with the seizure medications, as we'll see in a second, ion channels, neurotransmitter release or uptake, a whole variety of underlying pathophysiology related to seizures, and argues for the need of additional or multiple medications. Likewise, when we look at the pathophysiology of status epilepticus, it involves neurotransmitters, it involves metabolic changes, disruption of the blood-brain barrier, inflammatory processes that are started in status epilepticus, and again, a number of different targets for potential treatments. So I'm not going to give you the typical graph that everybody shows about the seizure medications, but this just gives you an idea. In 1857, bromides were introduced and identified as treating seizures. Over the intervening time, 43 different medications were approved at some point for the treatment of epilepsy. Now, not all of them are still around, but there were 43 medications that were approved, and the most recent one being ganaxolone a year ago. When we look at seizure medications, one of the things that starts to give us the idea that we need multiple approaches are medications and their mechanisms of action. I think most of us realize that the majority of medications work on ion channels, in particular sodium channels, but also calcium and potassium channels. But we also now have medications that work on neurotransmitters, especially GABA, drugs that work on synaptic release of neurotransmitters, glutamate, and other mechanisms. So we're starting to see that we can target different mechanisms of action with our seizure medications. I want you to keep this in mind because many times people think that a seizure medication is a seizure medication, and it doesn't matter about the mechanism of action. So this is very important. However, one of the things that we need to think about is that many times these are not pure mechanisms of action, that many times the drugs will have multiple mechanisms of action. So the older drug phenytoin, these are at least the 5 different mechanisms of action that have been identified as being antiseizure with phenytoin. So while we classify it as a sodium channel drug, it also has impact on calcium channels, potassium channels, and even regulation of a variety of neurotransmitters. Even with the newer drugs, like cenobamate, we identify it as working on voltage-gated sodium channels, but there's evidence that it works on GABA-A receptors. And I won't be surprised that as we study cenobamate more, there will be more proposed mechanisms of action for cenobamate. So even with our newer drugs, we have to think about multiple mechanisms of action. Another thing that we need to consider is adverse effects. And these are just more of the severe adverse effects. When we think about treating patients, we may have a patient who, for example, has mood problems, and we may want to avoid some of the drugs that have a higher risk of causing problems with mood. So even though a drug like levetiracetam may be useful, if they have some psychiatric diagnosis, we may need to think about other drugs that lessen the risk of having problems or adverse effects from the medications. So this is just a short list of a variety of adverse effects. I didn't put on here, and actually I probably need to mention it, the whole issue of DRESS that is becoming available, and there was just information pushed out by the AES that now the FDA has identified levetiracetam and clobazam as potentially causing DRESS, and a warning along those lines, along with cenobamate. I put this study in because it's very interesting and very, very useful, by Chen and Brody. The importance of this study was that even though we see increased use of newer medications, we haven't seen improvements in overall seizure control. The number of people who are seizure-free remains to be around 70% with the first or second seizure medication. The other thing to think about from a global perspective is the global access to seizure medications and treatments. This is the World Health Organization essential medication list. You can see a regular list, these are drugs that you'll hear need to be made available in every country in the world. You can also see that lamotrigine and levetiracetam were just added this year. And then there's a complementary list that includes a couple or some other dosage forms or ethosuximide. But this is a limitation when we think about treatments and guidelines. So how are we going to approach this? This is our overview, and I've told the various speakers, I'm not going to do introductions in between, so this is all you get. If you want their full bios and that, they're in the app or on the website. So Dr. Janine Conway from the University of Minnesota will help us think about older drugs and how they might be used. Dr. Jackie Bainbridge from the University of Colorado will then talk about some of the newer drugs and how we can use them. Dr. Christine Park, also from the University of Colorado, will talk about precision medications and precision treatment of epilepsy. Dr. David Vossler from University of Washington will help us think some about status, and we'll then end up with Dr. Archana Patel from Boston Children's, helping us to think about this more in a global perspective. What I'd like you to do, and I challenge you to do as we go through this symposium, is think about answers to these questions. How does it impact the care that you provide to people with epilepsy? What impact does this have on payers, insurance companies, pharmacy benefit managers, government programs, in the types of treatments and the types of drugs that they will approve? And then what messaging do we need to give about epilepsy, its causes, and its treatments? So with no further ado, I'm going to turn it over to Dr. Conway, and then everybody will follow immediately after her.
All right, well, I am very pleased to be addressing this topic today, and it will be gone but not forgotten, medications that have a role despite their challenges. Because I'm anticipating some of us in the audience have encountered patients where we're at a loss and we pick one of these older medications and somehow have excellent clinical results. No disclosures. So we're going to identify, and I'll share which ones I'm going to be talking about here momentarily. We're going to discuss the challenges, and that dictates to some degree why they have fallen out of first-line favor, and then create the plan for monitoring these less frequently used medications. So I will be discussing phenobarbital, phenytoin, carbamazepine, valproate, and felbamate today. Felbamate is now 30 years old. And so in framing this and even understanding how our prescribing practices have shifted, this is a data set from AHRQ from 2020 that's strictly prescription claims data. And what you see is phenobarbital alone is not reported. Felbamate doesn't show up at a frequency to be reported. And you can see phenytoin's a tiny piece of the pie, carbamazepine's a smaller piece of the pie, and then valproate. Now this is regardless of the indication. So it's likely that it includes uses beyond treating seizures. So let's start with phenobarbital. Phenobarbital has been with us for well over a century at this point, discovered to have anti-seizure activity in 1912. Primarily, the barbiturates were used because they were hypnotics and tranquilizers. Interestingly enough, at least in the US, this essentially predates a lot of our regulations around how drugs got approved. So it predates the need to prove efficacy and safety. And in fact, up until last year, no phenobarbital formulations had FDA approval. And so really at that time, they had to prove that what was in the bottle was what was on the label. And that was what the FDA was concerned about, was just strictly labeling at that point. But over time, it has fallen out of favor with almost use, mainly because we don't have a ton of clinical trials. A lot of our data comes from the mid-'80s from the VA co-op studies when it was studied against phenytoin and carbamazepine and primidone. And then it's mainly because of its side effect profile. It can be very challenging for patients to really tolerate it long term. And so over time, it's just not used particularly for maintenance. That said, still has a role, and you may find yourself needing to start it in a patient. And so it is the ILAE, like last 2 months ago, came out with their statement on neonatal seizures, and it is first line. So it will be used in that particular population. So status and in neonatal seizures. In certain channelopathies, there's been some data of reasonable efficacy, and so you may see it used in that case. There's also some very limited descriptions in the literature around its use along with bromides. And so our first FDA-approved formulation is now the preservative-free intravenous infusion that's used for seizures in term and preterm infants. From a pharmacokinetic perspective, it has a really long half-life, right? Well, at least 4 days on average in an adult population. And so there may be times where you really need something that's got nice, steady kinetics in your patient. It has some resiliency in case a dose is missed, and it has nice linear pharmacokinetics. So if you double the dose, you're going to get an expected doubling of the concentration. So it makes it predictable, and that lends itself to some advantages in certain populations. It is a significant enzyme inducer of cytochrome P450s and of liver enzymes. So if you ever look at a drug interaction chart or you're using a database, you will absolutely see phenobarbital causing a number of drug interactions. So having access to resources so you can anticipate some of those or work with other providers for your patient if it impacts other medications is key. All right, moving to phenytoin. So again, was being discovered around that barbiturate era, was shelved for a time, and then Merritt and Putnam discovered that it had anti-seizure effect. It has similar efficacy in terms of seizure control compared to phenobarbital. However, it was better tolerated, and so there was less patients discontinuing it when it was compared to phenobarbital. But again, it has also fallen out of favor for maintenance treatment. A lot of it's the side effect burden, just like Tim just described, Dr. Welty just described, and then a lot of challenges with its pharmacokinetics, which we'll get into. And additionally, as we've studied more about it, our use in elderly patient populations has also decreased significantly over time. So where does it fit now? Primarily status, and usually if it's possible, using the fosphenytoin formulation, which is the prodrug of phenytoin, and then refractory focal onset seizures. So why is phenytoin so tricky? Well, phenytoin exhibits nonlinear saturable metabolism. So as your dose increases, it saturates enzymes, the half-life gets longer, and it gets very difficult patient to patient to predict how phenytoin is going to behave and how they're going to react to it. And so there's a ton of population variability as well as intra-patient variability. So this particular slide just shows between age groups how different the enzyme kinetics look for elderly adults and children. And so this particular slide really addresses some of the data that we now understand around intra-patient variability. So this was a patient population that were nursing home residents that were on a dose that did not change, on no other interacting medications, and when blood levels were checked, you can see there is, in some cases, patients with an extreme amount of variability. So, same dose, nothing else going on, tons, and then some people that barely changed at all. And we still aren't great at predicting which one of these our patient is going to be. Adding to the trickiness of phenytoin is not all phenytoin is the same. So when we have this nonlinearity, an 8% change in dose can result in a significant increase in blood concentration or decrease depending on where your patient is at. And so keeping in mind that across the formulations, not all phenytoin is the same. Most of the phenytoin we work with is phenytoin sodium. That's 92% phenytoin, but two of our formulations, the chewable and the suspension, are 100% phenytoin. So even thinking about as you treat patients over the lifespan and their formulations may need to change, that's going to impact potentially a dose change when it doesn't even really look like a dose change. So, sum up some of the kinetic challenges. It induces metabolic enzymes. It's also a mess, kind of like phenobarbital, phenytoin, major enzyme inducers, gonna cause drug interactions. So your red flag needs to go up and start looking for drug interactions. Adding into that, we know that the primary metabolic pathways are 2C9, gets saturated, then it goes to 2C19, and there's genetic variability with those pathways. So you can start to see where all the impacts of variability are coming into play here. It has side effects we've actually already discussed. So there's concentration, the chronic side effects, and then it is subject to all the hypersensitivity reactions as well. Carbamazepine. So carbamazepine is discovered in the 50s. It begins getting use in the 60s and into the 70s. And so it has fallen out of favor to some degree for maintenance therapy, mainly because it's got also a ton of side effects and has a ton of drug interactions. But it also has some genetic susceptibilities for allergic reactions. So again, when it's been tested head-to-head against levetiracetam and lamotrigine, it has similar efficacy, but it's just not as well tolerated. So often it's not going to be the first line anymore for our patients. That said, it still has a role, and if you're working with any patients that are experiencing trigeminal neuralgia, still used a ton for those patients, and refractory focal seizures. So kinetics, significant enzyme induction, lots of drug interactions. It also has an interesting challenge with an active metabolite. So if your patient has kind of an average blood concentration and yet they're having evidence of toxicity, it could be that the epoxide is accumulating for some reason. So there may be a reason to check that and see if that's contributing to some of the things going on. It exhibits autoinduction of its own metabolism. So as you start a patient, their level may not increase until they kind of get their liver revved up. And so you'll see sort of a flattening and some unpredictability of the relationship of the blood levels to the concentration, at least initially. Hepatic issues and blood counts, blood dyscrasias can be a challenge with this one. Extended release formulations can improve the tolerability, right? So the half-life, because of the autoinduction, the immediate release formulations often require 2, 3, 4 times a day dosing, depending on the patient's situation. Extended release formulations can help improve that and improve their ability to adhere. And I would argue, at least in my practice, we're replacing it in younger adults, maybe not elderly, with oxcarbazepine because it offers similar efficacy, less significant drug interactions, and some reasonably comparable tolerability or slightly improved tolerability. Valproate was discovered to have anti-seizure activity in the 60s. As hopefully many of us are familiar with, we've been seeing a lot of data lately on the effects on children that were exposed to it in utero. So that has really limited its use in people of childbearing potential. So we knew about the teratogenicity, we knew about the neural tube defects, but we have a new appreciation for the impact on offspring. That said, there may be clinical scenarios where it's, despite that risk, it's still what the patient needs in order to best control their seizures. And so it absolutely still has a role for patients with juvenile myoclonic epilepsy, absence, certainly status, and it's being used outside of seizure indications as well. But everyone's trying to be mindful of the childbearing potential. So it's primarily metabolized through the liver. It has fewer drug interactions, and it has a tendency, rather than being a big-time enzyme inducer, to occasionally inhibit things. And so everyone hopefully is very familiar with the significant inhibition of lamotrigine, which means those two medications can absolutely be used together but need to be done carefully and deliberately. From an adverse reaction perspective, high ammonia levels can be problematic. So if your patient presents looking a little encephalopathic, consider getting a level. Thrombocytopenia, if your patient needs to go through chemotherapy and they're having a hard time keeping their platelets up, might be a reason why it falls off your list of a priority and where you want to use it in practice. And then sort of a very common, and the reason why part of the reason why we got a lot of extended release formulations is to help with the gastrointestinal irritation. So certainly there is a role for the extended release formulation, both the 24-hour and the sprinkles, to allow our patients to tolerate it better. And last, let's talk about felbamate. So this was really the first of the next generation. It was approved in 1993. That makes it 30 years old. And as it got launched and everyone was excited to start using it, we started to see cases of aplastic anemia and hepatotoxicity. And so that really led to then kind of a reversal, and we were more conservative with how broadly we were using it. And so it has basically fallen out of favor because of these reports of aplastic anemia and hepatic failure. And we know that it does offer a much higher risk compared to the general population risk of aplastic anemia. I'm sure if we query this audience, we will get lots of opinions about how to best laboratory monitor someone. If we're going to start felbamate, needless to say, you should at least get baseline labs of blood counts and liver enzymes. And, you know, there's recommendations of weekly, every other week, monthly. That has to be determined between you and your patient as to what you're most comfortable with. Certainly, as someone's on it long term, that interval can be extended. The challenge with labs is it doesn't necessarily provide advance warning, so it's important that the patient and their caregivers have a sense of what anemia and liver dysfunction might look like, because by the time you get the next set of labs, it may have already started. So current uses, refractory pediatric epilepsy is its primary target. That said, I've seen it occasionally used in adults as well. And there was a recent chart review that looked at 75 children with a variety of causes of epilepsy, and they felt like it brought value to improving half the cases seizure control, and they had good safety outcomes, so no reports of liver failure or aplastic anemia. And that's certainly consistent with the work that was done in the mid-2000s, basically saying, like, despite all these concerns, there's still a role for it, and we shouldn't necessarily remove it for the market. Kinetically, it's got a nice dose, linear dose concentration relationship. So if you adjust the dose, you can expect a similar shift in what that blood concentration might be. And it kind of had the opposite side effects of what we normally expect. So instead of making people real tired and wanting to take naps all the time, it actually caused some insomnia, decreased appetite rather than causing weight gain like Depakote can. So it really sort of shifted the side effect profile from what we had been used to for many, many years. So these older medications are very popular for therapeutic drug monitoring. We did it a lot. Lots of people investigated it. I think the reality is we can't just lock into those ranges and assume that they are, not everyone fits into those therapeutic ranges. So there are reasons to consider getting a blood concentration. It really is to establish an individual's therapeutic range and to help us optimize dosing. So then when life happens, we have a better sense of what might be going on with our patients. So whether they get acutely ill and they're vomiting and their blood levels drop, and they have seizures, or if something happens and they have to start a whole bunch of new medications that interact, if we have a sense of where their blood level is, then we can kind of readjust as needed. And then there are challenges with interpretation. So if you read a lot of the literature on therapeutic drug monitoring, like they were very scientific, right? We should get a trough level before they take their dose, and it was very kind of structured. The reality is we get a lot of just random sampling. We get convenience blood levels. When our patient's in the clinic and the lab is available, we get a blood level. So really having a sense of, like, did we happen to catch a peak concentration? And so it's higher than I expected, but given the timing of the blood level, maybe it's not something I necessarily need to be reactive to, versus like maybe I got a lower level than I expected because maybe I did really get a trough because of the timing of whatever's going on in the day. We will have patients that have good seizure control or side effects outside of the therapeutic ranges. And so just keep that in mind. And ideally, to be the most useful, the patient needs to be at steady state. Otherwise, it's hard to know what direction you need to go with that data, so that they've taken their medication for enough half-lives that concentration is nice and stable. And there may be times where a total or unbound concentration may be helpful in optimizing somebody's meds as well. So in closing, despite all these challenges, there still may be a need to prescribe these older medications, so being familiar with those and kind of having a sense of what you might need to do in addition is important. Pharmacokinetic challenges absolutely increase the risk of drug interactions and side effects. And so plan ahead to have a monitoring plan for signs and symptoms of toxicity, and consider which lab tests will be useful and how often you need them. And I thank you for your attention.
Thank you all for coming today. And thank you, Dr. Conway, for reminding me that not only does felbamate turn 30 this year, but so do I. We were born the same year. So my mission, as I have chosen to accept it, is to talk to you about some, not all, of the newer anti-seizure meds, ASMs, that we have on the market. I'm mildly conflicted, not really. These are our symposium objectives. We're going to identify newer anti-seizure meds, abbreviated as ASMs, used for epilepsy and seizures, discuss the efficacy of the newer anti-seizure medications, and describe clinical considerations of some of those newer anti-seizure medications. Now, I will say to you that in general, and this is a term of generality, is that we do have improvements over our older anti-seizure medications in terms of pharmacokinetic profiles, pharmacodynamic profiles, and also drug tolerability. And that's a general rule of thumb, because everyone should be treated as an individual and treated appropriately. As you can see, and as people that know me well, this is like my shoe closet. When you have options, it's a good day. So we have many, many options to choose from to help our patients with epilepsy and seizures. So let's first talk about eslicarbazepine acetate. This is a sodium channel blocking medication, more fast than slow. We know that it's indicated for the treatment of partial seizures in patients that are 4 years of age and older. We do have randomized controlled data that shows efficacy over some of our older anti-seizure medications, including carbamazepine and oxcarbazepine. So really, when you think about dosing considerations for this particular medication, it's a once daily medication, so it may have advantages over our older anti-seizure medication, carbamazepine, and then also oxcarbazepine. So it may be better tolerated in some individual patients and obviously help with adherence. So when you think about the benefits, we know this is a newer agent, so it may be more expensive than some of our older agents. We know that there's going to be dependency on that in terms of insurance, et cetera. But we do know that we have more flexibility, and we know that we have increased adherence because it's a once-a-day medication. When we think of the side effect profile with this medication, we want to think about our typical sodium channel blocking side effects, such as dizziness, ataxia, or balance issues. Lower risk of hyponatremia than the other counterparts that I've mentioned. So oxcarbazepine having actually the higher incidence of hyponatremia, followed by carbamazepine, and then are least likely to cause hyponatremia. However, it can cause hyponatremia in a small amount of patients, would be eslicarbazepine. Oh, and I want to say, you want to remember, because eslicarbazepine is metabolized into oxcarbazepine, you wouldn't want to use the two concurrently because you'll just have additive sodium channel blocking side effects. So now let's talk about lacosamide. Lacosamide, also a sodium channel blocking drug, but this is more of a slow inactivation. Indicated for monotherapy and adjunctive therapy for focal onset seizures, and in primary generalized tonic-clonic seizures in pediatric patients as well as adults. We do see clinical efficacy and tolerability with this particular medication, and it's been around for a while. So we know that we have that long-term data on safety and efficacy. We also know that lacosamide can also be given as an IV or oral route of administration. Obviously, we want to take consideration whether or not we're giving it in monotherapy or adjunctive therapy, and then also looking at potential drug interactions with other agents and monitoring the patient as time goes on. So this is a Schedule 5 medication. Our adverse effects that we see are, again, those sodium channel blocking side effects. Some of the ataxias, drowsiness, cognitive impairment, but much less so than we saw with the older anti-seizure medications. And I would say that that's also a benefit of most of our newer anti-seizure medications. Now let's take a look at perampanel. Perampanel is a competitive NMDA glutamate receptor antagonist. This is actually indicated for adjunctive therapy for focal seizures with or without secondary generalization and primary generalized tonic-clonic seizures. We do have efficacy in clinical trials, obviously, and it is a Schedule 3. I'd like to call your attention, there is a box warning. Now that's an update from black box warning. So we're kind of just coming up with, staying consistent with the times. So the box warning is for serious or life-threatening psychiatric or behavioral adverse effects. You can see aggression, you can see hostility, irritability, anger, and homicidal ideation. That's not obviously what we see most commonly with this medication, but it can happen. So the adverse effects that we do see more commonly, dizziness, fatigue, irritability, some weight gain issues in some individuals, and some balance issues. Let's move on to breviracetam. Breviracetam, same mechanism as we see with the leviracetam. So it's highly selective binding affinity for the SV2A protein. So it's indicated for partial onset seizures in patients 1 month of age and older as either adjunctive therapy or monotherapy. So we do see, obviously, efficacy in our clinical trials. This can be given orally or intravenously. We see long-term data that there is a sustained effectiveness of breviracetam with good tolerability. So it does have a more favorable psychiatric profile as opposed to leviracetam. So if some patients exhibit behavioral abnormalities, on leviracetam, breviracetam is a potential therapeutic option, especially if someone has good efficacy with leviracetam and maybe not with other anti-seizure medications. So this is a Schedule 5. I would say that this medication, breviracetam, is highly lipid soluble and penetrates the brain rapidly. So efficacy is seen very quickly with this medication, and you may not need to titrate this medication. And in most cases, you won't need to titrate the medication. Adverse effects, irritability, dizziness, fatigue, some balance issues, and some depression. So cenobamate, basically, as Dr. Welty has mentioned with his beginning slides, this does have a dual mechanism, starting out as a sodium channel blocking drug and now picking up positive allosteric modulator of GABA-A ion channels. It's indicated for the treatment of partial onset seizures in adult patients. You can use it as monotherapy or adjunctive therapy. I could say most notably that cenobamate, if you can obtain the highest dosing level, you'll see somewhat higher seizure freedom rates, maybe increased tolerability, or not increased tolerability, increased quality of life in patients, et cetera. So, but tolerability is an issue, getting to that highest dosing level. It is a Schedule 5. Titration is slow, so with this medication initially you saw higher DRESS rates. However, going back to reworking the dose escalation schedule and the dose, you now see that DRESS rarely appears to date. It can happen, obviously it has happened, but rarely at this point. So it's contraindicated in patients with familial short QT syndrome. Obviously that's something that you're going to monitor with this medication. You can see neurologic adverse effects such as somnolence, fatigue, dizziness, based on its mechanism of action, some visual changes, and maybe cognitive dysfunction, depending on your individual patient. This next medication is cannabidiol, which you can abbreviate as CBD. I probably could talk ad nauseum about this medication. I would say that this is Epidiolex as the brand name. The only reason I separate that particular medication out is I feel like it is very different than what patients can get from a dispensary, which I'm, disclaimer, from Colorado, so the wild, wild west. So we have dispensaries on every corner practically. So there is a difference because we know exactly what's in this particular medication. It's plant-derived, it's purified, et cetera. So that is very different than what many of our patients are getting from dispensaries. So we know overall the mechanism of action will decrease neuroexcitability. So it will decrease calcium, increase adenosine. We know that it blocks the GPR55 receptors and desensitizes our TRPV1 channel. So overall, decreasing neuroexcitation. Very efficacious in our patient population. So this is indicated for Lennox-Gastaut syndrome, LGS, Dravet syndrome, DS, and tuberous sclerosis complex, or TSC. So it's indicated for patients 1 year of age or older. Pretty well tolerated. What we see from the side effect profile is some GI discomfort, depending on the dose, depending on the patient, depending on whether or not that patient is of advanced age or not. We can see some liver function test abnormalities, et cetera, but pretty well tolerated. So adverse effects, other than what I've mentioned, you can see some weight loss in these individuals. You can see some insomnia. Obviously, that's why many patients are using CBD products over the market, is to help with sleep abnormalities. Fenfluramine has a dual mechanism of action. So it's a sigma-1 receptor and serotonergic agent. So it modulates NMDA or N-methyl D-aspartate mediated excitation. It's indicated for Dravet syndrome in patients that are 2 years of age and older. And there is a REMS program associated with fenfluramine. We may remember this medication as the weight loss medication, fen-phen. We do not see the dose is much lower than it was when it was used as a weight loss drug in combination. But we see a very different side effect profile. So we're not seeing the cardiac issues with it used at lower doses and not in combination. It is a Schedule 4. Adverse effects are what you would assume. So we're going to have decreased appetite, somnolence, some sedation, depending on the patient, diarrhea, et cetera. And then we have everolimus. So this mechanism of action, again, much different than we see with our other medications. So it's a mammalian target rapamycin or mTOR inhibitor. It's indicated as adjunctive treatment of adult and pediatric patients 2 years or older with tuberous sclerosis complex or TSC. Associated with partial onset seizures. So obviously we've got efficacy seen with many different clinical trials, but exists 3 trial, randomized, double-blind, multi-center, et cetera. So there was a demonstration of significant reduction in seizures in all study arms. The most common adverse effects that are seen with this particular medication are stomatitis, vomiting, nausea, upper respiratory infection, cough, rash, and pyrexia. Ganaxolone is a positive allosteric modulator of synaptic and extrasynaptic GABA receptors. The indication is for the treatment of seizures associated with cyclin-dependent kinase like 5 deficiency disorder in patients that are at least 2 years of age. There was a significant reduction in the frequency of seizures associated with this indication. It's generally well tolerated. You can see some pyrexia, somnolence, upper respiratory tract infections, etc. So this is weight-based dosing, and titration is required. Now, the next two kids on the block that we're going to talk about are not new molecules by any means. They're old friends. However, this delivery mechanism is much different. So we'll start out with diazepam nasal spray. It's indicated for acute treatment of intermittent stereotypic episodes of frequent seizure activity. So seizure clusters, acute repetitive seizures, and those seizure types have to be distinct from what the patient normally experiences, and they have to be on a baseline anti-seizure medication. So they're not just going to float de novo with diazepam or midazolam nasal spray. So it's indicated to break up those intermittent seizures. So efficacy is pretty quick. It's a rapid onset. Median 4-minute time onset from administration to stopping that seizure. 87% of seizure episodes used a single dose of diazepam nasal spray over 24 hours. And a majority of the patients really didn't show any evidence of sedation, et cetera, within 1 hour of taking the medication. So they completely came back to baseline, minus the seizure. So generally well tolerated. Just a few things to keep in mind. There are multiple dosing strengths, so you want to keep that in mind. It's not just one dose. And this is weight-based dosing, so you don't want to confuse that with just ordering a single dose. I think a lot of times we get into trouble with that, and it doesn't work because we're not getting the correct dose. When you order this and you have a prescription, you write a prescription for this particular product, it comes in a 2-pack, so you're getting 2 doses within that pack. Expiration of the drug is really 27 months from the date that it's manufactured. And to look and find out that actual date, you look at the foil blister pack on the inside of the packaging. The adverse effects are really pretty minimal. You can see some sedation, nasal discomfort, some rhinitis, et cetera. So, and dysgeusia, so abnormal taste or a change in taste. And then there's no real clinical relevant changes in respiratory rates that have been observed in those clinical trials. Now, the other new formulation on the block, not new drug on the block, but midazolam nasal spray. This is indicated for the same as diazepam nasal spray, with the exception of diazepam nasal spray was 6 and older. This is 12 years of age and older. So we do see efficacy, obviously, in randomized controlled trials. Primary endpoint was treatment success. So they were looking for a seizure termination within 10 minutes. And no recurrence 10 minutes up to 6 hours after drug administration. So very efficacious, and again, patients tolerated it very well. So in 27, almost 28% and 22.4% of patients in the midazolam nasal spray and placebo groups respectively experienced greater than or equal to 1 treatment emergent adverse effect. Again, it's generally well tolerated. And with this particular intranasal spray, you only have one dosing strength to choose from. Common adverse effects seen from clinical trials were the same that you saw with the diazepam nasal spray. So nasal discomfort, etc. So without further ado, these are my references, and I certainly appreciate your attention. Thank you.
Is it on? Yeah. Okay. Oh, there it is. Okay. Good afternoon. Thanks so much for inviting me to talk about this particular topic. We're going to move on to the P for A through Z and talk about precision anti-seizure medicines. And I'm thankful that we had the pharmacologist talk a little bit earlier about some of these agents, and now we're going to talk about how we choose to treat each patient with which agent. So I have no conflicts of interest to disclose, but I will state that most of this talk is going to include a lot of off-label indications and limited data from our controlled trials. Most of these are going to be small case series or single individual patients who have been reported, mostly retrospectively. So these are our learning objectives for today: to demonstrate that an understanding of the pathophysiologic mechanisms of some of our common genetic epilepsies can lead us to be able to select more appropriate agents for the individual patient in front of us. Unfortunately, this approach does have some limitations because we have limited clinical evidence because of the rarity of many of these conditions, and the diseases are often a bit more complex than they initially appear to be. So I think the first topic to discuss in this particular presentation is what exactly is precision medicine. And there are a lot of competing definitions and a lot of interest in this topic. I think, whatever it is that we decide upon, a lot of people are talking about it, as is evident by the number of articles that have been published over the last several years. For this particular talk, I've chosen to focus on the National Academy of Science definition, which kind of has several different levels of precision medicine. Our current state is rather imprecise, right? We're using the same set of medications, by and large, for all different seizure types and most of the patients that we see in front of us. What we're going to talk about today, I've highlighted there in blue, which is that we have the opportunity to do targeted therapy for some of our patients using this mechanism of disease. But the things that we really want to see and what truly define precision medicine is the potential to alter the disease course of epilepsy and its associated comorbidities. And that is a bit more rare and not necessarily something that we're going to focus on today. So another definition that I like is from the paper that I've cited there at the bottom, and we're going to talk about the use of an existing anti-seizure medication in a particularly defined group of patients in order to improve the outcomes of their particular disease. But I would refer everyone to this excellent article published in Epilepsia that talked about a number of the other different aspects of precision medicine. So its use in risk prediction, in treatment optimization, its use of electronic healthcare records to look at big data. How do other factors besides the disease state, like environmental and socioeconomic things, factor into outcomes? And then to use other things like metabolomics and transcriptomics to assess patients' response and the use of medications. This is another slide that I stole from this article that looks at a lot of what we're going to be talking about today, that many of these neurogenetic diseases and syndromes have been through a very similar pathway. It begins with gene discovery and the growing diagnosis of patients. Then many of these disorders get a natural history study or the accumulation of information about the disease course. Unfortunately, that often is outpaced. The pathogenesis understanding is outpaced by the genetic discovery, but many times we get small clinical trials, what are often referred to as N of 1 trials, where some amount of rigor is applied to the use of the medication. Maybe the parents track baseline seizure frequency, they give the agent, they monitor that same outcome, even they look at EEGs, and then potentially sometimes they even withdraw the agent to see if the symptoms will come back. And then again, we're also talking about the repurposing of these medications, and so those are things that I've highlighted here. So the first thing, now we're going to kind of get into the meat of today's topic, and we're going to talk a little bit about tuberous sclerosis and the use of vigabatrin in treatment for that disorder. We know, as we've heard from some of our other presenters, that the main mechanism of vigabatrin is the irreversible binding to GABA transaminase, which leads to an overall increase of this inhibitory neurotransmitter in the synaptic cleft. However, there is some evidence from a mouse model that it has effectiveness against the mTOR pathway, which is the part of the pathophysiologic mechanism of tuberous sclerosis. In a conditional knockout mouse model, those mice treated with vigabatrin had fewer seizures and better survival. And then in pathologic slices, they had decreased mTOR activity observed in both the hippocampus and the neocortex. So if we look at the clinical evidence, it comes from kind of two larger studies. The first showing a number of patients with drug-resistant infantile spasms who tried vigabatrin, and a very high percentage of the patients in that group with tuberous sclerosis were responders. And that response rate was kind of the highest among all of the different etiologies that we see for infantile spasms. And similar data was presented by the U.S. Spasm Consortium with a larger number of patients, about 400 patients, about 30 of whom had tuberous sclerosis, and vigabatrin was effective in about 62% of those patients, as opposed to about a third responder rate in the non-tuberous sclerosis group. So more recently, we've had some additional data, a meta-analysis of vigabatrin for infantile spasms, looked at about 7 studies. Unfortunately, only about 3 of them were randomized controlled trials, and the dosing of this agent was pretty broad and not very well specified in some of the studies. But when they were able to look at the data overall, about, again, 60-some% of the patients responded to vigabatrin, and if that was restricted to the methodologically more rigorous trials, the response rate was even higher, and that was, again, above what was seen in patients without tuberous sclerosis. Down at the bottom here, I've highlighted in orange what we were kind of very hopeful would be true precision medicine for tuberous sclerosis with the EpiStop trial that looked at whether vigabatrin could be used preventatively in children with an early diagnosis of tuberous sclerosis to ultimately alter epileptogenesis and some of the associated comorbidities that we see in this diagnosis. More recently, published in August of this year, was the results of the PREVENT trial. Some of the initial data in this trial, they randomized patients with tuberous sclerosis to either placebo or treatment with vigabatrin. And unfortunately, the numbers did not show improved cognition, lower rates of epilepsy, or less drug resistance in those patients. However, the bright side being that there was a lower incidence of infantile spasms, and the average age of onset for spasms was later in those patients. So hopefully we will see some more results from this trial and continue to address this potential question of whether we can prevent the development of these consequences for tuberous sclerosis. Next, we'll turn to KCNQ2 and its associated developmental and epileptic encephalopathy and the use of ezogabine. As we know, ezogabine is one of those agents that Dr. Welty talked about that kind of fell off of the list, but there is another agent that just completed phase 2 randomized controlled trials in adults for focal onset seizures that also is a selective potassium channel opener, so hopefully we will see similar results for this agent. Ezogabine, when it was available, was a positive allosteric modulator of a number of different potassium channels and acted to increase the number of those channels that were open at any given time, along with some other mechanisms. And the clinical evidence, again, for this agent is relatively sparse and probably not as relevant anymore, but it started with a single case report in 2013, broadened to about 11 patients who were treated, who seemed to have benefit when the agent was used earlier in the disease course, and potentially related to what variant type they had, although that was not necessarily borne out because of the small number. And then finally, in 2023, a case series of 8 patients that were treated with this agent. And 5 of those patients who had daily seizures at baseline experienced a significant response to this medication. That response was sustained in 4 of the children, and 2 of them were seizure-free. Fortunately, those children also showed some of the other benefits that we hope for with precision medicine, which were improved developmental outcomes. And when the agent was withdrawn, those children had a resurgence of symptoms. So they had some irritability, agitation, sleep, regression, those types of things. There have been also reports of the use of sodium channel medications in patients with this diagnosis, and the mechanism for that is that we think that sodium and potassium channels are co-localized at the axon initial segment. This may be mediated by shared genetic motifs in the code for these ion channels that mediate the action of anchorin, which kind of places them in this particular portion of the neuron. In addition, there are some evidence from mouse models that SCN1B can modulate the function of potassium channels. And so we think that these types of channels interact in some way, and perhaps that's why sodium channel medications can be used in a potassium channel disorder. The clinical evidence, again, is twofold. We have a small case series in patients treated from a number of different institutions, and about half of those patients responded to the use of carbamazepine, which is not something that's typically used for infantile onset epilepsy, but in this case, when you have the diagnosis, should be considered. And then there is also a more recent systematic review looking at a number of retrospective trials. It had a total of 217 patients in it, but only 84 of them had the more severe epileptic encephalopathy. They didn't actually really report outcome data for the more benign phenotype because those children had a very high rate of spontaneous remission, and so it was very difficult to determine if the agent actually was the cause of the cessation of seizures. When they looked overall at the patients with the developmental and epileptic encephalopathy, though, they did see that the highest response rate was had with sodium channel blockers, and that was a number of different sodium channel blockers that were used in the trials. Next, we'll turn to Dravet syndrome, a very well-known sodium channelopathy, and I think the question here is whether there does exist precision medicine. So the mechanism for Dravet syndrome being the loss of function in these sodium channels, specifically in GABAergic interneurons within the brain, and the majority of patients with this diagnosis have loss of function mutations, meaning that the sodium channel is no longer effective, although recently there have been some gain of function patients described. The currently recommended agents that we know about for treatment are clobazam, fenfluramine, and stiripentol that have been talked about, but none of those medicines specifically target the defective sodium channel, although there are some mechanisms, as we heard about from Dr. Welty, that once an agent is studied, we learn more and more about different mechanisms that may be at play. And Epidiolex, which is also indicated for the treatment of Dravet syndrome, may be thought to have some action at sodium channels as well. So what we do know, though, is that if we treat patients with Dravet syndrome with sodium channel medications, they often get worse. And so I think that is one area of precision treatment. There have been multiple case reports of that with worsening of the seizures, and that was seen with phenytoin that caused chorioathetosis in several Japanese patients. And one of those patients, I think, even had hypoperfusion abnormalities in the contralateral basal ganglia. And then there was recently a large cohort of patients from a Dutch study that indicated that use of sodium channel medications within the first 5 years of the Dravet diagnosis led to worse cognitive outcomes, and that was borne out even in a multiple regression analysis of that trial, or of that data. Another sodium channel medication, there's going to be a few more sodium channel diagnoses here that we'll go through, is the use of sodium channel blockers in SCN8A. Typically, children with this diagnosis have a gain-of-function mechanism where the channel acquires additional properties that it didn't usually have. And many of the patients have missense mutations. So the clinical evidence is a number of small case series that showed that children seem to respond to sodium channel blockers, especially high-dose phenytoin, which had, as we heard from Dr. Bainbridge, has some complications when using it, not Dr. Bainbridge, the other first presenter, who talked about using that and having a difficulty controlling levels, and that is especially true for children. More recently, there was another article that looked at how the response could be potentially correlated to functional assessment of these channels, and indicated that when the patients were responders, it often was because the mutation resulted in this increased persistent current, and that is how many of the older sodium channel medications work. When the sodium channel function was more complex and involved activation and inactivation kinetics, benefit from trileptal was not seen quite as much for those patients. Next, we'll talk about SCN2A, and I think the situation here is a bit more complex because these patients can have both gain or loss of function mechanisms. People are trying to figure out how to determine that, either using characteristics of the clinical presentation or predictive modeling, but that is neither of those are perfect discriminators, and that can make it complicated to choose a particular agent. And the functional consequences of these mutations can alter the sodium channels in a number of different ways that may also affect which sodium channel blockers are potentially effective. So the clinical evidence here is review of a case series showing a pretty good response in the epileptic encephalopathy patients, again using high-dose phenytoin, giving improvement in seizures in a large number of the people reviewed, and seizure freedom in 30%, which is pretty dramatic for this condition, which often has very severe and difficult to treat seizures. Other sodium channel agents have also been studied in individual case reports that I did not necessarily put up here through our slides. Next, we'll talk about perampanel and its use in glutamate receptor disorders. So we heard, again, that perampanel is a non-competitive AMPA receptor antagonist and acts against this synaptic transmission. And the clinical evidence for its use in glutamate receptor disorders is relatively limited. So only 2 single case reports, one being a 5-year-old girl who had classic symptoms of a neurodevelopmental impairment, movement disorder, and epilepsy, with frequent seizures and frequent bouts of status epilepticus, secondary to a pathogenic variant in GRIN1, which is one of the more severe phenotypes. And perampanel was started as add-on therapy, and this child had a control of seizures in addition to improved EEG background. And as I mentioned, with N of 1 clinical trials, when the agent was withdrawn, seizures returned. The second was a 1-year-old boy with a different category of glutamate receptor disorder, GRIA2 mutation, and these authors were able to do some additional functional studies to show that the mechanism was in fact a gain of function, and that the application of this agent in vitro was able to block the appropriate currents such that they felt comfortable giving it to this child at 2 years of age, and he did have improved seizure control and some developmental gains. So I think, as I mentioned, we're only kind of brushing the surface of what precision medicine really is, and there were a number of things that we did not necessarily go into detail for today, including the use of non-seizure medicines in many of these neurogenetic disorders. So, and I just put some examples here for us. So the use of fluoxetine, an SSRI, and KCNC1 that has, again, a single patient case report and some functional data. The use of quinidine in KCNT1, which had a lot of initial interest, but over time, the benefit for that medication seemed to be less robust than initially thought, but may be due to kind of an incomplete understanding of the pathophysiology of that diagnosis. We also have some data about the use of formiminopyridine in KCNA2. I just learned that this was apparently initially developed as a bird poison and somehow made it into anesthetics, and now we're going to use it in small children. Then we also have some evidence for the use of some other naturopathic and other agents, so L-serine in GRIN disorders, as well as the use of memantine and dextromethorphan, again with single case series or small amounts of data. We did not talk about pharmacogenomics, which is another important area and indicates to us that potentially we can choose medications based on how well our patients are going to metabolize and process those medications, whether they will have an adverse drug reaction to those medications, another important area. The emerging use of antisense oligonucleotides and other small molecules like microRNAs to treat epilepsy. And I highlight that because I think those are the agents that we are kind of pinning our hopes on to have true potential for disease modification. And clinical trials are currently underway for Dravet syndrome, SCN8A, also for Angelman syndrome. And then finally, the use of precision medicine to predict therapeutic response. So this was a large study that just came out in several hundred patients that demonstrated that some common polymorphisms in sodium channels were associated either to being a responder to those medications or to having resistance to those medications. Wouldn't it be nice if we could assess that before we put patients on those agents? So I think to summarize, what I will say is that we have discussed that many of our monogenetic etiologies for epilepsy are being more commonly diagnosed and can hopefully translate into more rational selection of anti-seizure medications, but that requires often a more precise understanding of the mechanisms of both the medication that we're going to be using as well as the disease that we're treating, and that is often the limiting factor because of the use of, or because of the need for functional data and again, genetic discovery that is outpacing our understanding of these diagnoses. I think that true precision medicine with the goal of, again, altering clinical outcomes is still on the horizon, and that overall it's a broad discipline that has a lot of implications other than treatment, which we've discussed today, but for public health, diagnosis, and prognosis. Thanks for your attention.
Good afternoon. My name is David Vossler. I'm from the University of Washington in Seattle, and I want to thank Dr. Goldman and Dr. Welty for the kind invitation and the privilege to be able to speak to you today. Many of my colleagues are here, including some of my trainees and people that I've worked with at other institutions, so it's really a delight to be here. We've talked a lot about anti-seizure medications, obviously, in various different situations, and my talk is focused on how to apply it in more emergent situations, which many of us face. These are my disclosures, and none of them are relevant to the talk. The learning objectives today are to first learn how to use the 2016 American Epilepsy Society guideline on the treatment of status epilepticus and newer data to bring it up to 2023 to develop a treatment protocol in your mind for how you want to treat established status epilepticus. And secondly, to formulate an evidence-based treatment protocol for refractory status epilepticus. So status epilepticus is not something that's new and has been really described over millennia, actually. You can go back to the Psychiku, which was a Babylonian text well over 1000 BC, in which were described many different kinds of medical conditions, but in chapter 4 they actually described epilepsy, and there was a reference here that reads, "The demon possesses him many times during the middle watch of the night. It may go on for some time, but he will die." And this is thought to be the first reference that's known and discovered of status epilepticus. Where does the term status epilepticus actually come from? Status epilepticus is a Latin term, but it's attributed to Louis Calmel in his thesis at the University of Paris 199 years ago. So next year will be 200 years old. And I don't speak French very well, but there you can see the French words which should translate to status epilepticus. So let's take a little look at some simplified definitions that we'll use operationally today. These are not all the types of status epilepticus, but these are from the International League Against Epilepsy, and you see the reference at the bottom, so these are the ones that are used today. I won't be talking about focal motor status epilepticus, or what we used to call, when I was in training, epilepsia partialis continua. I will be talking about convulsive status epilepticus, the most lethal and dangerous form, and it's defined there as overt convulsions lasting greater than 5 minutes or 2 back-to-back tonic-clonic seizures without full return of consciousness between them. It's quite a difference than when I first started in neurology and first started in medical school in 1979, when we had a 30-minute definition before we would call something status epilepticus, and there's reasons behind that, but those are well beyond the scope of today's talk. I won't be talking about non-convulsive status epilepticus in any of its forms, absence, focal sensory, or focal impaired awareness seizures, but the definition is that those go on for 10 minutes or more. Again, to stick with definitions for one more slide, I want to just point out that this is from Simon Shorman's work and others. This reference goes back now 12 years, but really hasn't changed. I think for the most part, we can agree that I think the first term, developing status, is a little bit arbitrary, perhaps a little hard to know about. But these are seizures that are leading up to status epilepticus, and I would argue that probably, unless someone should develop status epilepticus in the hospital, these are going to be happening in the pre-hospital setting. Established status epilepticus, however, is well defined, and this is something that we've talked about just in the last slide, 5 minutes of duration or more for convulsive status epilepticus, and this is where therapy needs to be started, again, ideally in the pre-hospital setting. Refractory status epilepticus, for those of you that may not know this, is the failure of 2 adequately dosed antiseizure medications in different drug classes. And we'll come to that in a minute, what those drug classes are. But there's an example right there, phenytoin and abenzodiazepine. And then super-refractory status epilepticus is defined as status that's persisting despite more than 24 hours of anesthetizing anti-seizure medications, and we'll touch on those in a minute. So let's move to the guideline, the 2016 guideline from the American Epilepsy Society on the treatment of convulsive established status epilepticus. There are other guidelines. There was a guideline that was published a little bit earlier in this, I think it was 2012, from the Neurocritical Care Society in the United States, and there was also a guideline published by the European Federation of Neurology, but I'm going to just discuss the AES one because because this is the AES. Okay, so first phase treatment, I like to call it first phase, and you'll see in the literature the terms are first line. And I shy away from using the term first line because to me that implies the best. Let's start with this. These are phases of status, right? So that's how I'm going to discuss it today. So first phase is, for sure, to give bolus of intravenous lorazepam, diazepam, or phenobarbital, or intramuscular midazolam. I'll get into the evidence behind that in just a second in the next slide. The doses are really critical, and the reason that I put these in bold is because I want you to sort of emblazon these in your mind and make sure that at your home institutions or whenever you speak on this, you emphasize the importance of using full doses. And I'll get into that a little bit later because there's many studies all show the same thing, is that patients with convulsive status epilepticus in particular are underdosed to the detriment of the patient. This is in children and adults. Both many pediatric and adult studies show the same thing. So the doses are as follows. Intramuscular midazolam is given 10 milligrams for adults if a smaller person or a child, 5 milligrams, as you see there, a single dose. This is level A quality of evidence, highly likely effective. Lorazepam intravenously can also be given 4 milligrams if you have IV access, but getting IV access can sometimes be difficult in a patient who's having a continuous tonic-clonic convulsion. So the dose is 4 milligrams, not 1 and not 2, it's 4, and again, smaller doses for littler individuals. Diazepam, again, the dose is 10 milligrams, and you may repeat that. Either the lorazepam or the lorazepam or diazepam doses once. And again, these have level A quality of evidence ratings. Now, for areas of the world where perhaps benzodiazepines are not as readily available, the AES guideline is that you can substitute and give phenobarbital 15 milligrams per kilogram as a single dose, or rectal diazepam or nasal or buccal midazolam. Where did these recommendations come from? What were the studies that were behind these? So we have 3 excellent Class 1 randomized controlled trials. The first is the Rampart study published in New England Journal of Medicine. I can't believe it's been 11 years now. This was an NIH-funded study, and this was in the pre-hospital setting that looked at intramuscular midazolam versus IV lorazepam, and it found that intramuscular midazolam is superior. How could that be? We know that a medication that's given intravenously is going to penetrate the brain faster, is going to establish a plasma concentration with a much shorter Tmax, time to maximum concentration, than an IM medication. Well, the problem is that, again, getting back to if the patient's having convulsions, it can be very difficult for healthcare providers to start intravenous lines. And so now we have an approved, it's an Israeli company that makes this particular IM midazolam formulation. My understanding is that's the same company that made the compound for the Rampart study. It only just recently, however, became approved by the FDA and available in the United States. From another NIH-funded study that was done in San Francisco by Brian Aldridge and Dan Lowenstein's group a number of years ago now, again, can't believe it's been 22 years, compared lorazepam 2 milligrams to diazepam 5 to placebo. And I guess no surprise here, but surprises do happen, but not in this case. Benzodiazepines were superior to placebo, and lorazepam exceeded diazepam. Now, you're going to say, hey, Dave, those doses are lower than what you just said in the last slide. Yes, that's true. They're effective, but again, stick to what I just said in the previous slide. 4 milligrams for lorazepam, 10 for diazepam in an adult or a larger individual. And then going back further, Dave Tryman's study, this was funded by the Veterans Administration, was a comparison that showed the lorazepam's better than phenytoin. lorazepam was equal to phenobarbital, and lorazepam was equal to diazepam plus phenytoin, which was the last was common practice when this particular study was done. Okay, so you've given a benzodiazepine, now you're in, again, what I like to call the second phase, not second line, and loading doses of what should we give to follow up the benzodiazepine. I was taught when I was a resident at Boston University 39 years ago by my mentor, Tom Brown, give a benzodiazepine, and then we gave phenytoin. At that time, we didn't have IV valproic acid. We certainly didn't have levetiracetam because that didn't come around until 1999. So it was phenytoin or phenobarbital back in those days. Well, now we like to use phosphenotoin because it has a lot of less problems. As you know, the dose is 20 milligrams, and phosphenotoin is given the abbreviation 20 milligrams phenytoin equivalent, PE, per kilogram. You give a single dose, the maximum is listed there, the maximum speed is listed. The evidence behind this is actually not that good, but nevertheless, this is based on what we had in 2015 when the study, this particular study was done and the guideline was completed. We now have some subsequent evidence, which I'll get to, but it was level U at the time, which is insufficient evidence. Valproate had level B evidence, but at a high dose was what was recommended in the 2016 guideline, 40 milligrams per kilogram with a maximum dose of 3,000 milligrams. I'm going to bet you that a lot of people in this audience and your institutions are not using those large doses. I'm going to also bet that levetiracetam is probably not used, and unless you're following these guidelines, probably not used by many people in your institutions or in the communities around your institutions at 60 milligrams per kilogram. That's the recommendation. The maximum dose, again, this would be for larger individuals, is 4,500 milligrams. The evidence was slim for that as well. Better evidence actually for phenobarbital, but phenobarbital, as Janine talked about, has more side effects. It's an old drug that has a long history, obviously, and has a lot of side effects. Well, fast forward now a number of years, this ESET study was about to start. Actually, there was a lot of preparation for this. It was a huge study, very difficult to conduct. It was being worked on. At the time the AES guideline came out, we didn't want to wait in putting out our guideline for the results of ESET. But we have it now, so it's been 4 years. I can't believe it. I remember when we presented this at Baltimore AES meeting. The paper came out in November of 2019, and we talked about it in Baltimore, and then the pandemic came. But anyway, so ESET was a class 1 randomized controlled trial. It included adults and children. You see the doses. No surprise, the doses chosen for this study were exactly what was recommended in the 2016 AES guideline. You can see them there. What happened? Well, cessation of convulsive status epilepticus was seen in equal proportions of patients with LEV, phenytoin, and valproate. That's phosphenotoin, I guess I should say. So this, based on this is a class 1 study, randomized controlled trial, done perfectly well, according to the American Academy of Neurology clinical practice guidelines. Let's see if you see that down here. This is the reference that I'll use throughout. This is the current CPG process manual from the American Academy of Neurology. Yes, it's from 2017. That's the current one. So this would, as a single class 1 study, that gets what's called a level 2 or level B level of evidence rating. So there were no differences in the level of consciousness or major safety events, equal efficacy, essentially equal. Numbers were extremely close. More episodes of hypotension and intubation with phenytoin than with the others. Not significantly greater, but numerically greater. There were numerically greater deaths with levetiracetam. Not sure why, but that's just how it worked out. Okay, so that gets us up to 2019. Well, what do we have since then? Well, the first one actually came out in 2016, as you can see here, the SAMU-CAPRA study. This was patients, these are adults now. This was a class 1 study. It was pre-hospital convulsive status epilepticus. This was done in Europe, and all patients received 1 or 2 milligrams of clonazepam. Our European colleagues here in the audience today and those in hybrid meeting at home or their offices will say, yeah, we use clonazepam a lot more in Europe than in the United States. So just keep that in mind for the Americans in the audience, that clonazepam tends to be more favored in Europe for the treatment of status epilepticus. And this compared clonazepam plus either levetiracetam at a reasonably high dose or placebo. Interestingly enough, there was no difference. So that suggests that clonazepam is likely equally effective in convulsive status with or without levetiracetam, interestingly enough. A little bit smaller study, but of older adults, so over age 60. And as someone who's over age 60, I'm a little appalled at that. But anyway, I would say mature adults with convulsive status epilepticus, despite large dose, thank you very much, large dose of lorazepam, were given, in this case, relatively lower doses than what we at AES recommend of either LEV or VPA, and control was no different. Moving on, we have a couple of nice studies. One was done in New Zealand and one in Australia. The Eclipse and the Concept studies, these were done in children, fairly large numbers, 286 and 352 respectively. And you see the doses were fairly large for levetiracetam, standard dose for phenytoin. I think probably should have put fosphenytoin here. In any case, slight differences, slightly more often and a faster termination of convulsive status in the Eclipse study with LEV than with phenytoin. There were a few more serious adverse effects, hypotension, decreased level of consciousness, worsened focal seizures in the Eclipse study with phenytoin. In the Concept study, actually the phenytoin group did a little bit better in terms of efficacy and no serious adverse effects. So I think we can take these two together as level C evidence. These are from class 3 studies, so 2 class 3 studies that were well done, but open label, so they are class 3, as this is level C evidence that these two doses in children are probably about equally effective. Other studies, just bringing you more up to date, there was a study from Iran that looked at 80 children. You see they were fairly young children, all 10 years of age and younger, even infants, comparing lower dose, what we would consider at AES lower dose valproate to phenobarbital. Phenobarbital was more effective, interestingly enough. A recent study, the China 2P versus V study, this updated a prior study. This was had some enhancements to how it was done. And that looked here recently at 69 adults, and you see, again, the doses employed, higher dose valproate, typical kind of dose of phenobarbital, and phenobarbital, again, this was adults, was a little bit more effective, but had more side effects, as Dr. Conway was talking about early. And finally, this year, a study that came from Japan looked at 173 adults who had got a variety of different doses of diazepam. This was not highly scripted. This was an open label study, and physicians were allowed to prescribe the appropriate dose that they felt was appropriate for their patients. So you did see a lot of variety or variability in the dose of diazepam that they were given, and then they were randomly assigned to full dose fosphenytoin, but arguably maybe a flaw in the study, relatively low dose. I mean, that's 1,000 milligrams is an average maintenance dose, single maintenance dose of levetiracetam, and one could argue maybe that should have been higher. What they found was pretty similar in terms of cessation of seizures, and serious AEs again tended to favor fosphenytoin. So, wrapping it up for established status epilepticus, what can we say? Taking the American Epilepsy Society 2016 guideline and moving that now forward to 2023, that the newer Class 1 ESET study, randomized controlled trial in adults and children, these 2 large Class 2 studies that were done in adults that I mentioned, the Eclipse and Concept studies done in children, and others that I highlighted there, showed no consistent major differences in efficacy, maybe some slight differences with a little more side effects with phenobarbital or phenytoin, but not statistically significant in controlling established status epilepticus. So now, what I want to say is that the American Epilepsy Society is working on a new guideline for the treatment of status epilepticus, and it's going to take all of these studies and any others in a very careful, systematic way, review of the literature, performing a systematic review and meta-analysis, and then we'll use that to issue a new guideline. We're doing this now jointly with the Neurocritical Care Society. So unlike in 2012, when the NCS published their guideline, in 2016, AES published our guideline, the two societies are working together, funding it jointly, and hopefully we're aiming for 2025 for that to come out. But from my perspective in review of the literature, and I didn't conduct a systematic review, I would say that probably there's not going to be major fundamental changes from the 2016 guideline. I was told by Dr. Welty, I think, that there's an ILAE guideline underway for status epilepticus, and so I don't know too much about that. This is the actual algorithm that is in the 2016 guideline. If you're not familiar with it, please become familiar with it and use it in your practices and teach your trainees this guideline. I will say, again, I said at the outset that guidelines are just not being followed well. There have been many papers that have talked about this. One of the more recent ones, and a nice one from several German-speaking countries, so Germany, Switzerland, and Austria. Kellinghaus was the senior author, looked at this sense registry, and this was a nice study that looked at over 1,000 patients and how they were treated. It wasn't a treatment study, but a prospective treatment study, but what it was a look back at what had been done, specifically in terms of benzodiazepines, and benzodiazepines, in this case, lorazepam was used in the European countries, but they were using lorazepam. Dosing was significantly lower than what all the guidelines recommend in refractory convulsive status epilepticus and non-convulsive status epilepticus than it was in the patients who were not refractory, suggesting that, maybe if those patients had been more appropriately dosed following guidelines, there wouldn't have been so many refractory cases. Also, the time to treatment, in stroke we talk about door to needle time. Well, you talk about the time of onset of convulsive status epilepticus to the first treatment was 30 minutes for convulsive, and it was 2.5 hours for a non-convulsive status. So they also found that use of benzodiazepines and higher total dose of all the anti-seizure medicines together used in the first phase of treatment led to shorter time to control of both convulsive and non-convulsive status epilepticus. And as I said, I don't want to get into it because it'll go beyond my time limit, but there are multiple other adult and pediatric studies. Some nice work from Toby Lodenkemper's group at Boston Children's have found that the same thing occurs in children as in adults. Now, moving on to refractory status epilepticus, which we call the third phase, you have the option, in this case, of using other intravenous anti-seizure medications, non-sedating anti-seizure medications, other than what you used following the benzo. So let's say you give them a benzodiazepine, you follow that up with 40 mg per kg of levetiracetam, IV bolus, and they're still having convulsive status. What next? Well, there's an argument that you could say, well, I'm going to use IV lacosamide or phenobarbital, phenytoin, or valproate if I didn't use it in the second phase. But there's a lot of people that are like, no, time is brain. We need to stop convulsive status as quickly as possible. Just move rapidly to anesthetizing drugs, which would be ketamine. Increasingly, people are using ketamine a little bit more, but historically have used pentobarbital, propofol, or midazolam by continuous infusion. I will say that, in terms of sort of fair balance here, there are a number of observational studies that have suggested that the use of the rapid moving to anesthetizing anti-seizure medications could lead to longer hospital stays, more complications, and worse outcome with the continuous infusion of the anesthetizing drugs. And some of the studies suggested that step therapy, in other words, moving to other non-sedating anti-seizure medications, might avoid these complications. There was a nice Swiss study that was just published this year in epilepsy, if some of you may be familiar with this, 246 adults, class 4 retrospective study. A large number of them had non-convulsive status epilepticus, and they found the opposite. So I think the jury's out on this, and being on the this joint Neurocritical Care Society, American Epilepsy Society guideline team. There are 40 of us that are working through right now what are called the PICO questions. We've got them just about defined. We've got 14. We need to pare it down to 10. But anyway, we are going to look at not just convulsive status epilepticus and not just initial treatment, but we are going to look at things like non-convulsive status and refractory status epilepticus in this new guideline. So I'm going to call it tentatively the 2025 guideline. Hopefully it'll be a little bit more comprehensive than our current 2016 guideline. In any case, what do we know about treating refractory convulsive status epilepticus, or titled here in the slide, convulsive RSE? Well, Dr. Welty and Dr. Bainbridge and I were three people that were on a task force that I formed a number of years ago that decided this is a problem that needs to be looked at. At the time, however, it wasn't our task force here at AES wasn't focused in a way to do a true systematic review or meta-analysis, so we couldn't publish an actual guideline. This became more of a comprehensive review, but it's sort of the best that we've got right at the moment, at least I think, and I'm biased, obviously. But in any event, looking at the literature, surprisingly, the only medication, anti-seizure medication, that had enough studies in refractory status epilepticus to come up with anything other than a level U, or insufficient evidence rating, was lacosamide. And there were 2 class 3 studies and 14 class 4 studies when we published this comprehensive review 3 years ago for IV lacosamide. And insufficient evidence for all these other single drugs and combinations of drugs. So again, we'll take another look at that in the upcoming more comprehensive guideline that we're doing with the Neurocritical Care Society. This is just a table of the drugs, common doses, maintenance doses, terminal half-life, serum levels. That's in that review, and I'm shamelessly plugging our review, Tim. Okay, a couple of new studies. We're getting closer to the end now. Newer studies in convulsive refractory status epilepticus. I realize these acronyms get a little confusing, so I'm going to speak them out. A couple of 2 new studies that were published here. The Morse code study, that was a class 3 study in adults, and this was a multi-center study in patients with, compared midazolam to propofol. And patients who got propofol were a little bit more at risk of needing a second class 4, or not class 4, continuous IV anti-seizure medication, i.e. midazolam. So good outcomes were seen in nearly equal numbers of patients. So this was an adult study. We don't tend to use propofol as much in children, so hence, you have to keep that in mind, of course. Ketamine, however, this was a study from University of Pennsylvania, looked back at some very young children, single center, retrospective, but 69 severely ill children. The median age was infancy, so 0.7 years, and they did show good seizure improvement in that very young cohort. Shifting gears, cluster seizures, and this was something that Dr. Bainbridge covered a little bit, and I don't want to, avoiding brand names, which that's fine that she used them, I'll just stay away from them. So the dosing for these new devices that we have does depend on weight, and I totally agree with Dr. Bainbridge on that. Fortunately, the device that we have that's approved in the United States, you have a wide selection of weight-based dosing, and I've already kind of tipped my hand now a number of times that I think dosing is important, and I think Dr. Bainbridge, based on her comments in her earlier talk, suggests that she probably will agree with me on that. Consider weight-based dosing. Our pediatric colleagues have no trouble doing that. Why should the adult colleagues? And I'm an adult neurologist. Okay, intranasal device comes diazepam. What am I? I'm sorry. I was pointing to this is the rectal. This is the rectal one there. This is the intranasal device that comes in these dose availabilities here. The intranasal midazolam device only comes in a single amount, 5 milligrams, but you can repeat it 10 minutes later. So keep that in mind. I've been unable to have contacted the company in Israel to get more information on this intramuscular midazolam auto-injector, and I don't have much except that it is FDA approved. This was the one that I believe this is the same one that was produced for the military, the U.S. military. It was used and deployed during conflicts, and it's my understanding it's the same device that now is FDA approved. So this is, I think, to be used by more trained individuals, like in the pre-hospital setting, medics, et cetera. But I've made numerous attempts to contact the company to no avail. So if somebody has more information, we can talk about that during the discussion. And my last slide, I'll just put a plug in. AES did do a review. Juan Ochoa did a nice review of superrefractory status epilepticus. This is now 2 years ago. But I hate to say it, but probably better than that is now a systematic review and meta-analysis that was just published in JAMA Neurology 2 months ago. And so if you're interested in superrefractory status epilepticus, I'm not going to have the time to cover that today, but I will point you to that systematic review and meta-analysis. So, the impact on clinical care. I hope I'm driving the point home that we want to use full doses of benzodiazepines for established, I should say, convulsive status epilepticus, and they are listed there again. For convulsive status epilepticus that persists after benzodiazepines, I'm listing here the 2016 guidelines, and again, the more recent literature seems to support those. There's nothing to suggest in the guideline in the studies that have come out more recently that would go against those 2016 guidelines. Phenobarbital, again, if you're in a more resource limited area, phenobarbital may be an alternative, again, probably with more problems with sedation, et cetera. Convulsive refractory status epilepticus, it's not clear in my view, you may discuss this and argue with me, and that's okay, that one should move immediately to an anesthetizing ASM or try a second non-sedating ASM. We can probably debate that, probably we will. And again, cluster seizures, again, I would suggest weight-based dosing. So with that, I thank you for the honor and the privilege of having this opportunity to talk to you about status.
Okay, so thank you for having me. For this final talk, we're going to take a little bit of a different angle and look at epilepsy and anti-seizure medication treatments from a more global perspective. So we've had a really nice series of talks showing us kind of where epilepsy management has come pharmacologically over the years and what's on the horizon. And as someone who practices in Boston, you know, this is really great for me when I'm taking care of some kids in Boston who have really difficult to manage epilepsy to know that, to borrow the analogy used before, I have a lot of options in my closet, and there are many things that I can still try, and even if that fails, there are things that coming out that may help them in the future. As someone who also practices in Zambia, it's incredibly frustrating because for even the simplest epilepsies, I often can't even access the medications that have been labeled as old and often disfavored. So I'm hoping that through this talk you will see some of these issues and hopefully see what we as a community need to do to move this forward. So I don't have any relevant financial disclosures. The learning objectives are to identify the key gaps in anti-seizure medication availability and accessibility globally, to understand the impact of the WHO essential medication list on epilepsy care, and to recognize the actions that we as a global epilepsy community need to take to help address some of these inequities. So I think we all know that the burden of epilepsy around the world is quite high. There's an estimated 50 to 70 million people with epilepsy, with 5 million new cases annually. But what is always striking to remember is that 80% or more of these people are living in low and middle income countries. So essentially, the places that have the lowest amount of resources to manage the condition have the highest burden. And this leads to disproportionate epilepsy treatment gaps existing over the world. So the epilepsy treatment gap is defined as the number of people with epilepsy who are not on appropriate treatment. So as you can imagine, there's a number of factors that we have to understand to get an accurate number here, which can be very difficult. First, you have to identify people with active epilepsy. So in places where you don't have providers who recognize it, communities who recognize it, or there's a high level of stigma, people may not be seeking out care, and so that number is estimated to be very grossly estimated in regions such as sub-Saharan Africa. Then you have to know what appropriate treatment is. So are the people with epilepsy who've been accurately diagnosed now having their diagnosis and treatment of the underlying causes, and are they being treated as per international guidelines and standards? And so this leads to multiple different things that we have to consider. There's not only the epilepsy treatment gap, but there's a diagnostic gap, there's a therapeutic gap, and all of these lead to an increased burden. Despite this limited data globally, we know that in the United States, the epilepsy treatment gap is under 10%, and in many places much lower. And in many low and middle income countries, it's above 70 to 90%. So if you do the math on that, 50 million people around the world living with epilepsy, 80% in low and middle income countries with a 70% epilepsy treatment gap. There's well over 30 million people around the world who are not on appropriate treatment. So how do we work on this? Like, who works on this? So the WHO, the World Health Organization, has an essential medication list. So this may not be something that many of us in the US use a lot of the time, but for a lot of the world, this is where medications are being selected from. The essential medication list is basically a core list of medications that's determined to be the minimum requirement in basic healthcare facilities for priority conditions. And priority conditions are defined as medical conditions with public health relevance that have safe and cost-effective treatments available. Epilepsy very easily falls into this. So globally, this list will then influence what national formularies will have on their list, which then will impact what's available in governmental hospitals and what is on national health insurance schemes. As of 2017, the basic medications at the time were phenytoin, sodium valproate, carbamazepine, and phenobarbital. So just think back to the talks we've had and what was there just a few years ago. And what is good to know is that in the 2017 Neurology Atlas, it did seem that most of the national lists were in correlation to these medications that were listed on the EML. However, when you went a little bit deeper, only 62% of countries around the world reported that they had these medications consistently in their primary care facilities. Many of them were saying they only had one or two of them, and that was give or take. And when you think about that and when you know how these work, it could be that they had carbamazepine one month and phenobarbital the next month. So for any of us that are treating epilepsy, we know that's not an adequate way of managing things. So there's persistent gaps not only there, but in pediatric formulations, rescue formulations, and neurodegeneration anti-seizure medications. So we saw this list earlier. The list has changed this year. It's been pretty exciting in that levetiracetam was added thanks to the efforts of Arjun Sen, ILE, and many others. And lamotrigine was moved onto the list from the complementary one. The complementary EML basically is similar in treating priority conditions, but meant for higher level centers. So as you can see, as of this year, this is the list of medications. And think of the 43 plus that have been listed and the many side effects and the many issues with this. So while this is not a bad place to start, it's definitely not adequate. When we look back at what's actually available and accessible, it's even worse. So the International League Against Epilepsy did a survey in 2021, and as you can see in the orange bars, those are high-income countries. In the maroon, those are upper middle-income countries. And then the blue and the brown are showing you low middle income and low income countries. And fairly consistently for most medications, there's less than 50% consistent availability for these medications in low and middle income countries, which is hugely problematic. For pediatric formulations, I am a pediatric epileptologist. Pediatric formulations are even harder to find. And if you're thinking, well, they can take a tablet and compound it, that requires education, that requires consistency, it requires people following a standardized recipe because otherwise dosing can be dramatically different. They also can't really cut the tablets. If you're trying to dose a child and titrate them when they're 10 kilos with 200 milligram tablets, it's very challenging. And then when we talk about rescue medication, so we just had a very nice talk on rescue medication availability and what we should be doing. So here is the algorithm for AES. I'm aware that this is an American guideline, but it is one that is used broadly around the world as well. And when we talk about what options are on there, how do we use these in places where they don't really have all of these? So 80% of African countries report they have a shortage of rescue medications greater than 2 times a year. Globally, only 30% of countries report that they never have shortages. It's pretty dramatic. When you're looking at the guidelines themselves, the availability of the various medications are incredibly limited as well. So IV diazepam is available most of the time, IV lorazepam in less than a quarter, and IV midazolam in less than a third. So when you're looking at even just your benzodiazepine options, they're limited. Your formulations for rectal diazepam, intranasal midazolam, also very limited. So I saw that that's one of the alternatives that has been offered for places that don't have some of the other options, but those don't exist either. And then as was highlighted in the last talk, yes, phenobarbital could be used, but there are other complications to that because you also need ventilatory support, which is then going to be a gap. So while IV phenobarbital and phenytoin are the most available next-line agents, the shortages are still common. And then in terms of IV valproate or levetiracetam, those are rarely available. So other barriers that exist are costs, which is not surprising. But what may surprise you to know is that the absolute cost for anti-seizure medications is fairly similar around the world, despite variations in per capita income. So what that means is in the United States, if 500 milligrams twice a day of Keppra or levetiracetam is, say, $100 for a month, it's going to be $100 US to someone who's in Kenya. That is completely unacceptable because their per capita income is much, much lower. So recent data from WHO has shown that a month of minimal dosing anti-seizure medication can cost over a month's wages. And I want to emphasize this is minimal dosing. When you actually look at these reports, they're talking about starting doses. Most of us are using much higher doses for our patients. And when you're buying these medications, you're not just buying what your doctor has prescribed and it's a set price. You're paying per the number of pills you have to get, which means the higher the dose, the higher you have to pay. Surveyed pharmacies in Africa have also shown that regulations on phenobarbital has led to increased costs, paperwork, and just a whole bunch of reasons that they just don't want to stock it. So what had been one of the most reliable medications in the region is now much harder to get sometimes. Distribution and supply chain issues are a huge problem. Many low and middle income countries are often importing their medications, and we saw during COVID how much this can impact an already very fragile system. Geographic barriers is another big issue. So and I'm going to speak to Africa as I know it best, but this is a problem in many rural areas where they have very few medications and most people have to travel to capital cities to then get other options. So for example, in Zambia, carbamazepine or phenobarbital is potentially available in most of the rural areas, but you'd have to travel to the capital city, which can be bused by 9 hours or more before you can actually get other medications. And there are financial incentives through some health insurance schemes in some of these countries to keep these in the capital cities, which then compounds these geographic barriers. So, why should we care? Well, it's obviously a human rights issue. It's an equity issue. We know that with appropriate treatment, as it's been stated, up to 70% of people with epilepsy will be controlled. So that was highlighted at the beginning as we've had all these things come out and we still are at 70%. But hey, we can do 70% and we're not meeting that yet. And the cost, and this is the cost that is still put out by WHO, and perhaps it's a little bit higher, but the cost is low. $5 US per year or a little bit more, but it's quite low for the most basic of medications. And that's that's the bare minimum standard, and we're not meeting it. I'm not saying that's what we should be doing. We should be reaching much higher, but that's the bare minimum, and we're still not meeting it. And as has been highlighted really nicely today, is that epilepsy is not a one-size-fits-all condition. So even if we manage to get 1 to 2 older generation medications consistently available in the majority of the world, it just simply isn't sufficient. It's been listed really clearly that the medications that are older have a lot of side effects that we don't want to use in our patients here, and we shouldn't be wanting other people around the world having to use them. So we really need to advocate for more relevant medications on the World Health Organization's essential medication list, which then translates to national formularies and health insurance schemes. And we should also be thinking about this when we're writing guidelines on medications. People are following these everywhere. And when we're writing the guidelines, we need to think about what should be available and then complementing that by pushing towards making them more available for everyone. Education's a huge component, but I can tell you that while there's been lots of data to show that you can pass shift epilepsy care to primary health care providers and make a big difference, and you can actually change perception that epilepsy is a very treatable condition, if you don't give them the treatment, they're going to fall back and thinking it's untreatable again and stop caring. So we're kind of falling into the cycle where we really need to now move forward on making sure that the treatment is accessible in addition to education. And we're in a great time period to do it. So, I think most of you are aware that the World Health Organization, ILE, and others are working on the Intersectoral Global Action Plan on epilepsy and other neurologic disorders. This is in place, and we now have the public health stage to make a difference. And a key goal to this is that 80% of people with epilepsy have access to appropriate, affordable, and safe anti-seizure medications. So to conclude, in resource-limited regions, access to any anti-seizure medication, even the oldest ones, can be a challenge, much less appropriately tailored therapy for an individual. And guidelines that are written from national and international organizations should be considering best care practices and feasible adaptations for everyone around the world. The World Health Organization essential medication list influences what medications are available to people. So we as a community should be advocating for change. And as I said, individuals did that with adding levetiracetam, and we have opportunities to continue to do that. So basic access to medications is a human rights issue, and epilepsy care globally will not move forward until we start working on it. Thank you.
So I want to express appreciation to each of the speakers. We have plenty of time now for question and answer, so I'm going to ask them to come up here and sit down at the table and open it for questions and discussion and comments from the floor that you may have. So. Yeah.
We're all trying to figure out where we're supposed to sit.
The neurologists are working on their orientation.
Yeah, we've got to get organized here.
And I'm having a problem.
Tim?
Yes.
Jim Cloyd, University of Minnesota. I wanted to follow up on Dr. Vossler's comments about underdosing in terms of first phase treatment of status epilepticus. We have a huge problem and a great opportunity. In the ESET study, we had an opportunity to take a look at dosing for both adults and children prior to enrollment in the study. The settings were home, transport, and the emergency department. And in every category except one, there was greater than 50%, in some cases over 80% of underdosing episodes using the AES guidelines. The only place where adequate therapy or dosing was given, it was in children using rectal diazepam. And we hypothesize that the availability of fixed dosage delivery systems, which more likely ensured adequate dosing, was the reason why these children got an adequate dose. Now, the opportunity is we can improve outcomes even before you get to ED by promoting what Dr. Vossler said, which is adequate dosing, which has been shown to be safe and effective. Thank you.
Thank you. Dr. Vossler, any comment?
Am I on here? Okay. Yeah. Thank you, Jim. I appreciate that. I didn't know that, and it jives with what again. I didn't prepare to talk about all of these studies. There are many of them, but in every study, patients are underdosed, and I think it brings up a good point that when patients are prescribed appropriate weight-based dosing, and that's what the parent caregiver has. Whether it's intranasal or it's rectal in the older days before intranasals were available, then that's what they're going to give. And that's actually really intriguing. I'll remember that comment because obviously, the parents are going to give what is appropriately dosed. And unfortunately, what they get in my own emergency room falls short. And despite my repeated requests to step it up. So again, I think that that's an important point. Thank you, Jim.
I would add to that for pediatric epilepsy providers, we have also shifted away from diastat because it's not as socially appropriate as some of the intranasal medications. And so I think we have to be mindful that if we had those formulated doses of diastat and now we have something else, we should choose that mindfully to get the parents the right dose that they don't have to worry about.
May I ask you a follow-up question on that, Kristen?
Sure.
And so, being an adult neurologist, I'm ignorant. So that's not surprising. And certainly for older kids and obviously all adults, there's obviously it doesn't have to be overstated the reason people don't prefer the rectal route, right? But with no indication for the U.S. midazolam nasal spray below age 12, and with a dose which is fixed at one dose, which is 5 milligrams, what do you do? Do you in the youngest of kids, very young kids, still use rectal? Just okay. Yeah. Okay.
I think we use it for very young children, but by 6 and school age, we'd like to get them to something
to the nasal. Yeah. Okay.
Hi. I just want to highlight a point that I'm working in a very underserved area in the Central Valley, in California. So we see a lot of refractory epilepsy patients. To identify the etiology and address it from the very beginning is as important as this phase of treatment you are talking about. Because if you're, for example, if it's an autoimmune epilepsy, if you don't start IVIG, steroid, or in the beginning itself, you are not able to break the sequence of stuff. So, and the other thing, most of the focal refractory epilepsy, maybe because of the tumor, or a stroke, hematoma. So then you need to do the resective surgery. I had a patient, repetitive, when you stop the anesthetic medication, the seizure will come back. Then finally you need to do the resective surgery. Even then seizure will not stop. You have to think about the VNS and the other neuromodulation procedures. So this is a whole spectrum, not just highlighting on these medications. That's one thing. And then the issue of you highlight the middle income, lower income countries. The problem in Central Valley, we majority of our patients are immigrants and poor Hispanic patients, and they don't have a good insurance. So we fight with all the insurance companies all the time to get these new medications, and then there is no sustenance. You may get randomly for a few months, and then we have to again fight with the insurance company. It's a problem for us too.
Yeah, very good comment. And that really gets to the questions that I asked at the end of my presentation, is how do we present to insurers the need to have multiple medications available, and the fact that epilepsy isn't just epilepsy, is epilepsy for every patient, that there's all sorts of underlying etiologies, and trying to get them to understand. I think there's someone here.
Yeah, hi. Larry Seiden, I'm in Atlanta. Really a great set of discussions, and mine is more of a comment. I started my training 30 years ago when we had so few choices, and I will counsel most of my patients, de novo, new onset patients, The good news is we have lots of good choices. The bad news is we have lots of good choices. There's no way to know what's going to be right for that individual. And again, so that the idea of the precision, it only works once you really have more diagnostic capability to be able to say what's going to work for which individual. And so we spend all of our time profiling folks and saying, well, what's sort of the best category? I think one of the biggest problems, and you know, this is for us as a society, is, and I mean the American Epilepsy Society, not, you know, in the more global sense, people still don't accept that seizures are dangerous. Right. They don't have this idea. It's like, oh, you've only had 2 seizures last month. That's great. And it's horrible. And so, David, when you talk about, you know, be aggressive, you know, people are giving a 0.5 milligram of lorazepam and then wait a half hour to see what happens. We have to work so hard to get our colleagues in general neurology, sort of the primary care neurologists, as well as emergency departments, internists, hospitalists, which is an explosive, you know, specialty, to accept and understand that this is actually serious. You know, it took a long time to get brain attack and stroke into that domain, but I don't understand why epileptic seizures are not accepted as being something as bad and as dangerous.
Yep. Thank you for the comment. Anybody want to respond? Or?
Me?
Okay,
I'm having trouble hearing you, Tim. Yeah, thank you, Larry. I'll try to unpack that set of comments, but and I'll reference just status epilepticus and cluster seizures. And I couldn't agree more. You know, it stems from, I think, our training, which starts with, you know, primum non nocere, right? Do no harm. And I think so many physicians are, at least in the United States, are very concerned about the repercussions if they give benzos and harm the patient, i.e. they get respiratory depression, that it sets up this fear of that, oh, I hurt the patient, now they're intubated because I gave them 2 milligrams of an adult 2 milligrams of lorazepam. What we somehow have got to do, and this is, I think, a big, broad question, is how do we do it in an organized way, is develop an education program, because we can look at these studies, and every single one of them shows that the lower dose of lorazepam or whatever it is, benzo, is the one that's going to be correlated with a much higher chance of respiratory depression rather than the other way around. It's counterintuitive, but not if you think about it, because the ongoing seizures, that's what is going to cause, in the majority of cases, respiratory depression and not the benzodiazepine. So the studies are replete, I hope, and we're looking at that. And I know that one of the PICO questions that at least one, if not 2 of the PICO questions that we've now settled on for this new AES/NCS guideline surrounds those questions exactly. So more to come. You know, we'll hopefully have that answer, you know, in a year and a half. I'm thinking about a year and a half, given the process. It takes a long time to do this work.
Good. I think we have a question over here on the right first, and then we'll come back over here.
Thank you. I'm Michelle Samaritano, and I'd like to emphasize the treatment gap. I really enjoyed the entire conference. I've had an experience in the 1990s of going to a conference called Epilepsy in the Developing World in Beijing, China. There were 10 representatives from North America, and the rest were from the rest of the world. The treatment gap was the emphasis of most of the conference, but I also want to point out there was the role of traditional medication, traditional medicine. And most of the patients, even in Beijing, received a combination of traditional medicine along with the Western medication.
China, do you want to?
I mean, I can agree that in many regions, traditional medications are used, and It's by our colleagues who are practicing medicine in other parts of the world, that is viewed with differing perceptions as well. In some places they work very well together, in other places the dangers of that, because it's not monitored the same way we talked about Epidiolex and CBD and the monitoring of that, it can be challenging as a practitioner. So I certainly think that is an avenue that that should be and is being explored for helping reduce the treatment gap. But at the end of the day, I think we also need to focus on just making a lot of these treatments more accessible, because they're what we think are the appropriate treatments to be available.
Yeah, and I'll add a comment because I've also done a lot of work in China and somewhat familiar with traditional Chinese medicine. Two concerns. One is we don't know about interactions between Western medications and traditional Chinese medicine. So that's an area ripe for study. And I know that I have a few colleagues who have been working not in the epilepsy area, but with some other medications. So that's number one. The other thing, oftentimes with traditional Chinese medicine, adverse events don't get reported. And in talking with Chinese colleagues, they often will say, yeah, this one can cause liver failure, or this one can cause renal failure. So we want to just recognize that they do also cause adverse effects that we need to be aware of. Okay, going over here.
Thank you all for your wonderful talks. I had a question for Dr. Vossler. With the emerging data supporting the use of ketogenic diet in refractory epilepsies, is there utility in the keto diet for super refractory status? And is the new guideline going to address these kind of diet therapies or non-pharmacological methods?
Yes, I didn't have enough time to get into that. That wasn't really part of the scope of what I was given for today's talk. But super refractory status epilepticus, yes, there are a number of studies that have looked at that in a fairly uncontrolled way. And some of you may know that just about 2 days ago in Lancet Neurology, a study was published looking at ketogenic diet versus, I can't remember what the standard medication treatment was, in young children with super refractory status epilepticus. And I believe that was, I think that was it. I'd have to look it up. I just saw it in passing and mentioned it to a colleague, and then didn't pay too much attention to it. But look in the December issue of Lancet Neurology, and they talk about the efficacy of ketogenic diet. And in the I think the other place to look would be at that systematic review that I mentioned that was published in September, because that was again a very thorough systematic review and meta-analysis. And you can also look in our paper that we did, published in Epilepsy Currents, I guess it was about 2 years ago. Good quality studies are kind of lacking, but yeah, ketogenic diet is one of the modalities that is used. Yep.
Hi, I'm Sonam. I'm a pediatric epileptologist at Mount Sinai in New York. Excellent presentations. I had so much to learn from each one of them. I had a question about a clinical case as such. Let's say in a case with refractory focal epilepsy, if patient's not responding to any other class of medications, do you ever worry about adding more than 2 sodium channel medications at the same time concurrently? And how do you tackle, how do you monitor for potential complications?
So absolutely, but it does become more problematic. So you'll definitely see more of those sodium channel blocking side effects. So the dizziness, the ataxia, and I think sometimes it goes unrecognized, especially in certain populations, so developmental disabilities. So I was consulted to go and talk to a group of people, and they presented one case, and that person was actually someone who was just crawling around on the floor, and that was a change. And it basically had to do with multiple sodium channel blocking drugs together. Now, having said that, sometimes you can get away with the lower doses of each medication, even using the same category. But if it's preferable not to, and I'll defer.
I would agree. I mean, I think I when I talk to trainees, I think the point I try to drive home is that most that larger studies indicate that use of more than 2 seizure medications together at any given time is more likely to cause side effects than it is to produce additional efficacy. And that the only kind of synergistic activity shown between all of the anticonvulsant medications is between lamotrigine and Depakote. And so any other combination, typically the goal is to combine different mechanisms of action. And I do usually try to avoid double sodium channel medications. I think the only time that I really have done that has been when I have a child with a sodium channel disorder, where I want to, get more activity in that particular regard. But otherwise, I think it causes more problems than it helps.
Can I add to that? So I'm going to present the adult counterpoint to that, and that is that there was, I won't name his name, but the past president of the AES and has gone on record a number of times at these meetings and outside these meetings as saying it makes absolutely no sense to combine 2 sodium channel blocking drugs, and you should always use drugs with different mechanism of action. And again, Tim may know who that is, I won't say, but because I don't want to embarrass anybody, and he's not here to defend himself either. So, but I would say that I totally disagree with that. I've seen many personal case examples, take it for what it's worth, not studies. There aren't studies on this that I'm aware of, any quality studies, high quality study. But my personal experience is absolutely you can use sodium channel blockers in adults, I'm not speaking for children, together. But to Jackie's point, the problem is this. I can't tell you how many patients I had on lamotrigine, and I added lacosamide. And first of all, not all sodium channel blockers are the same. Jackie spoke about rapid inactivation, slow inactivation, conformation. There's conformational changes. We won't get into all of that, and I think we need to maybe, Tim and Alicia, at some point in the future, because I think it's a contentious area. Not all sodium channel blockers are the same in terms of their mechanisms. Secondly, as Tim mentioned at the outset, these drugs, some of them have a single mechanism of action, but most of them have multiple mechanisms. So I've seen absolutely patients on lamotrigine and lacosamide do well together, but the issue comes up, and it's coming up a lot now with cenobamate. Patients are on lamotrigine, lacosamide, oxcarbazepine, Esli, pick your other whatever, sodium phenytoin, not many people on phenytoin, and that's a problem with cenobamate because there's a pharmacokinetic interaction. But you do have to watch out for the dizziness, diplopia, blurred vision, ataxia, as Jackie mentioned, and that will limit your ability to go up on doses of cenobamate. So if a patient, let's say, is on lacosamide or lamotrigine, they're not seizure-free, you want to push the dose of cenobamate, but you can't. You've got to back down on the pre-existing drug that didn't work in the first place. That's what I don't understand. Like, if you're adding a new drug, a new sodium channel blocker, and you're running into side effects, don't stop. Keep going, but lower the concomitant sodium channel blocker.
What about cardiac? Like, do you monitor with EKGs? Because sodium channel blockers can potentially, like, QT prolongation and things like that. So,
2 years ago at AES, we had Jackie French and Barry Goodall and I and David Auerbach and Leonard Berghardt from Selgrenska, who was a cardiologist and had done a lot of work on cardiac effects of sodium channel blocking drugs, really took a critical look at the evidence, and we published in Epilepsy, and then it was jointly published in Epilepsy Currents, and look in January 2021. Both journals, we published our summary there. There are some concerns. It's complicated, but truthfully, for lamotrigine and for cenobamate, the literature really just don't stand up at this time. Lacosamide has some issues, and you need to look at that. And carbamazepine definitely has it, and so does phenytoin. Phenytoin has. So those 3 drugs, carb, phenytoin, and Lacosamide are the three that probably have the most well-documented cardiac issues. The warning from the FDA was based on in vitro data, and the FDA went back to every original manufacturer of every one of those drugs, even Pfizer, which bought Parke-Davis, was the innovator of phenytoin, and said, you need to do additional studies. So those studies were ordered 2 years ago. I don't know what the results of those, do you know, Jackie, or Tim or Janine, what those studies showed? Yeah, I know that there are going to be representatives for the FDA, from the FDA here at this meeting, so if I find out, we'll
Thank you.
let that know.
I would add, just to clarify, cenobamate actually shortens the QT interval, whereas the others prolong. So there are differences, even though they're sodium channel drugs.
Right.
There are differences in the cardiac effects.
Big differences in the EKG effects, yeah.
Thanks so much.
Yep.
And I will just add to Dr. Vossler, we don't have good clinical trial data of using these drugs together, but there are some data sets from insurance claims. And when you have people on multiple calcium or sodium channel blockers, they have a higher utilization of things like emergency department visits and increased visits because of side effects. So there's at least one study I can think of. There might be a couple where they've really, it's blunt, right? It's looking at essentially like claims data, but it gives you a sense that's part of a population basis. So you had less utilization, like if someone was taking, you know, a sodium channel blocker and like Keppra, that type, or levetiracetam. So there is blunter data out there.
There's one more over there, I think I can see.
My question is for anyone in the panel regarding the FDA approval and the clinical trials, especially in pediatric patients. Specifically, the epilepsy, as we know, it's an age spectrum disease. So how do you, we don't start the clinical trials in the pediatric population to begin with. We usually do it in adults, and then we adjust the dose for the pediatric use. So can you comment on this, please?
I'll defer to my pediatric colleagues for now. Your thoughts?
I agree. We don't have a lot of data sometimes when we go forward and use it. I don't know if Dr. Moffat has anything else to add, but we do use it safely considering the evidence we get from the adult trials, right? And we look at that carefully. We adjust the dosing, and it comes to pediatrics later as a result.
Yeah, I just had dinner with a colleague last night, and we had this same discussion, and I think it's frequently motivated by the larger adult population and the less restrictions in doing clinical trials for adults and financial motivations, and then it kind of trickles down, right? So you start with 18 and older, then the company will go for an indication from 12 to 18. They may go for 2 to 12. Nobody goes for under 2. There is some safety data that indicates that we can translate and extrapolate once we get to 12. How to do pediatric dosing. But I think the overall discussion is, as you bring up, is about mechanisms, right? And I think we've seen this in pediatric and adult cancer, that if you spend time looking at pediatric cancer mechanisms and design drugs to treat those, they translate to adult cancer medications too. And so I think the same could be said for pediatric epilepsy. If you look at specific mechanisms of pediatric epilepsy, often genetic epilepsies, you will find things that will help adults. I mean, I think the development of ezogabine was driven by benign familial neonatal seizures and families that had potassium channel mutations, and that has now translated to adult use therapies for partial seizures. So you have to look at all of the pathophysiologic mechanisms that result in epilepsy, and that will hopefully at least give you some generalizability for the treatments that you develop. And I think we neglect that for pediatrics, most definitely.
I will add, I know that the FDA, within certain restrictions, does allow extrapolation of efficacy data from adults to children down to certain age ranges. So they do allow that, but it still doesn't address the issues of dosing in children, the issues of potential differences in adverse effects in children, as well as if it's approved in adults, there usually or typically aren't dosage forms available that would be applicable for children.
And just to add to that, it also can be harder to get it covered by insurance companies, or for things like using Diastat still or rectal diazepam for under 6. It's not driven necessarily by data on the safety of that, but by what is affordable.
Yep.
Yeah, good. I think I see someone. One last question.
I don't have a question. I just wanted to thank all the speakers. This is a talk that I was really looking forward to, and as a trainee, I have learned so much, and I was inspired so much by everyone who spoke today. So thank you.
Okay.
Thank you.
That's really good to hear.
Yeah, what a wonderful way to end. Thank you very much. Thank you, everyone, for coming and sticking around.
I remembered my
Have a good rest of the
question.
meeting.